This is Kate Wakeland from Neuroendocrine Cancer Australia, and welcome to Facebook Friday. It's the weekly live broadcast that we do every week. I'm not seeing a lot of action on my computer, and I think it might be just one of those cloudy, slightly drizzly Melbourne afternoons where sometimes the internet's not working so flush, not working so well. So we'll see how we go. We'll forge ahead. It looks a little bit more healthy than it did about 10 seconds ago. So thank you to everybody who's joining us. So once again, my name is Kate Wakeland. I'm the NET Patient Support Nurse with Neuroendocrine Cancer Australia, and every week I like to hop into our Facebook private discussion group to address the topic of the week and answer some FAQs. So that's what I'm here for this week. And it's been a couple of weeks. So I was on a break last week sampling all of the scones in the Dandenong Ranges, and I can give you my recommendations if anyone wants them. But back with things this week, and it's been really lovely to be back with the community and seeing all of the really fascinating discussions and learning all of the things that I keep learning from you all. Before I get to the topic of today, I just wanted to make sure I acknowledge the traditional owners of the land that I am broadcasting to you from, which is the land of the Wurundjeri people of the Kulin Nation. Would just like to pay my respects to elders past, present and emerging. One of the things I love to do, especially as the weather's getting a little bit cooler in Melbourne, is go for a run along the Yarra River. And after last week's scones, that's definitely what I need to be doing more of. In the Woiwurrung language, that is called the Bitterrung, and I know that that's a very special body of water for the Indigenous people of where I live. So I like to try and remember that when I run along that river, and just use that as a way of feeling grateful for where I am. And I know that you are joining me from all over the place, either via our Facebook private discussion group, or later on via YouTube. So just extending that acknowledgement to where you are joining me from today. This is a back to basics video. So we did one a few weeks ago where we started off really just looking at, well, what is the neuroendocrine system, and what are neuroendocrine tumors, and where do they grow and how do they grow. I'm just trying, with a bit of practice at these videos, I'm realizing I've got quite a capacity to ramble, so I'm trying to be a little bit more succinct so that people can just watch the video that's relevant to the question that they're asking at the time. So let's see how we go. But before I launch in, there's just two things that I wanted to say. The first thing is, if you're in Australia and you've been trying to keep on top of what's happening with the COVID vaccines, it has been really confusing, and it feels like every time I try and think, okay, I'm going to bring myself up to speed with what's happening with the vaccines, there's new information and new stuff coming forward. So if you are watching this video and you know it's several weeks or even several days afterwards, just feel free to disregard the coronavirus vaccine stuff, because it will probably be out of date by the end of today. But the recommendation for people with cancer is still very much that vaccination is strongly advised. So we know that people with cancer, if they contract COVID, they tend to do much more poorly than people who are healthy. So that advice has been very consistent all the way along. The issue has been around the AstraZeneca vaccine particularly, and the risk of clots, blood clots, and also this very small risk of allergies with, and the focus on that was the Pfizer vaccine, but any vaccine has a risk of allergies. So quickly, the short answer is always talk to your doctor and be advised by your doctor about vaccines and you. But the strong overarching advice for people with cancer, including NETs, is that the vaccines are very highly recommended. And I'll make sure I put some links to the current information so that you can get access to that after the video. The other issue currently in Australia is that the recommendation has been that people under 50 don't have the AstraZeneca vaccine, and it seems like they're going to be prioritising the Pfizer vaccine for people under 50 in that cancer, people with active cancer phase, which is phase 1B. That also includes me. I haven't had a vaccine yet either. My daughter, who's 21, had a AstraZeneca vaccine, and she's fine and dandy, but I've been told I need to wait for a Pfizer vaccine, so I'm hoping that I can get access to that really soon, but I don't know anything more than anyone else about that. But yeah, as I said, I'll put some links in the notes because I know this information will be dead and buried almost by the time the live feed's finished. They'll probably announce new stuff. It's just a really rapidly evolving situation. The other thing I just wanted to give a huge shout out, and it's a real celebration, is that the federal government have announced the funding to be developing an optimal cancer care pathway for neuroendocrine cancers. That's really exciting. It's something that we've been advocating for very strongly for a number of years, and it's been actually quite a lot of work for our consumer advisory group particularly, who have really helped shape and guide those messages, and people who have come along to, driven for hours to meet with the health minister, Greg Hunt, writing letters to their members of parliament, sharing videos, sharing whole lot of action at a very much a ground level from our patient community, our consumer advisor group, and our board and our staff team. So we're hugely excited that there's been an announcement of funding towards this, and especially in a COVID environment where, if you were a health minister, you'd be forgiven for thinking the world was just about COVID, and it's really exciting to see some prioritisation of this cancer, which is nowhere near as uncommon as we all thought, even a couple of years ago. And so we really want people and clinicians, patients and clinicians, to be having strong guidance as to what the optimal care pathway is. What's the consensus for recommendations for people in their care. So that's really exciting, and we're looking forward to working with the bodies who are writing that care pathway as we go along, and we'll keep you in the loop about news as that emerges. Before I want to talk about the back to basics part 2, really importantly, and I said this about the COVID vaccines, and I'll continue to say this every video we have, the information that I'll talk about today is general in nature only. And so for your own individual situation, please do talk with your doctor. Neuroendocrine tumors, if you've been around for 5 minutes, you'll know that we're an incredibly diverse bunch of cancers. So it's an umbrella term for a really a group of cancers that can behave incredibly different, both from tumour to tumour, but also in person to person. So I was talking to someone yesterday and saying, it's like when you see a stand of tomato seedlings in the nursery. And they're all essentially the same, the same kind of genetic makeup of the tomato seedlings. They're all kind of been, essentially cloned from the same tomato seedlings. So they're really very much the same plant. But if you put them in 10 different gardens, they'll behave in 10 different ways. And also, if you plant them in Tasmania, they will do a very different thing to if you plant them in Dubbo, or if you plant them in Geraldton, or if you plant them in Brisbane or Townsville. So neuroendocrine tumours will behave really differently from person to person, as well as from tumour to tumour. So this part 2 of our Back to Basics, we're going to be focusing in on Carcinoid Syndrome. The last Back to Basics, I'll make sure there's a link to the notes, but so we're not going to be talking too much about what neuroendocrine tumours are and all that sort of stuff. I'll leave you to watch that video if you need to catch up on that. But we're going to be talking about Carcinoid Syndrome. I'm going to be talking a bit about that. I'll mention other hormonal syndromes, but that won't be the focus. I'm going to talk about when it happens. I'm going to talk about what happens. I'm going to be talking about what we do about Carcinoid Syndrome. So that's my shopping list, that's my to-do list of things to talk about today, and my aim is to try and stay on track and keep it snappy. So I can't see any comments. It's telling me it's live, so what it means is that I can't see if there's anyone asking questions. So I don't know, maybe there's no one asking questions yet. Maybe just say hi if you can see this, and maybe I'll be able to see the comments. But look, if not, I'm just going to forge on through and try and anticipate what you might be asking. And also, I can also look in the comments afterwards and help answer questions afterwards if need be. So what is carcinoid syndrome? Such a good question. We hear neuroendocrine tumors being referred to as carcinoid tumors. So sometimes that's an old-fashioned, out-of-date name, but sometimes that makes us think that all neuroendocrine tumors should give people carcinoid syndrome, and that's actually not the case. It's actually only a fairly small percentage, so much less than 50% of people have carcinoid syndrome. Carcinoid syndrome is where there is an overproduction of serotonin, which is one of our digestive hormones that helps us, under normal circumstances. That's the hormone that makes the, amongst lots or the partially digested food squeeze through our small intestine and large intestine, and it's part of the process that turns what is your sandwich at one end into what comes out the other end in a relatively reasonable period of time, not too fast, not too slow. When the body's working properly, we don't even know about this hormone doing this job. What happens with carcinoid syndrome is that we have an overproduction of hormone. And we talked about that in the last video, that neuroendocrine tumors, in the process of becoming, devolving from a normal neuroendocrine cell to a tumor cell, is that they kind of lose their ability to function properly and they don't regulate themselves very well. So a normal neuroendocrine cell within your gut will realize that you've had some sandwich. It will say, right, we need to squeeze some stuff through, and it will do that job hopefully in a fairly orderly fashion. What happens when there's tumour cells is that they behave really erratically. Sometimes they still respond to the signals that your body says to say, I've had a sandwich, but they go into complete overdrive and produce way too much. Or sometimes they're producing serotonin when you haven't had anything to eat and you're trying to sleep and your body's going, no, we don't need to digest anything. We don't need to move anything through right now. But the tumour's going, no, my purpose in life is to produce lots of hormone. And so it's very unregulated and usually way too much. What that means is that you get a whole bunch of symptoms, and some of the classic ones are bright red in the face, and it looks like a hot flush that you might get if you're a female over a certain age going through menopause. So that often that times accompanied with a complete hot flush feeling as well. Diarrhea is the other classic symptom, and that can be really very frequent. So I have some patients where they're going somewhere between 15 and 30 times a day. So you can imagine, if that's not you, how much that might limit your lifestyle. People find it difficult to get to the shops, let alone go to work or go to doctor's appointments. So a lot of people have found ways of managing that, like downloading the public toilet map along the way so they can sort of work out where they can have a pit stop. Often people also need to carry a spare set of clothes and some wet wipes with them. So, this has a huge impact on people's lives. We've got some, probably I'll say this now and I'll say it all the way through, we've actually got some resources, some printed resources for things like dealing with diarrhea. So I'll make sure that there's lots of links in the notes. So this one probably is one to just read through the notes and have a look through the resources that are linked to. Some of the other, apart from the hot flushing and the diarrhea, sometimes people get a real wheezing, like a shortness of breath. And actually, carcinoid syndrome can be one of the things that people are trying to get answers to for many years before they get their diagnosis of neuroendocrine cancer. And so sometimes people are misdiagnosed with asthma because they're getting this wheezing. Anxiety can also be an impact from this, and so sometimes you're feeling really jittery and really anxious, and your heart you're getting heart palpitations. So it's that kind of thing that are hallmarks of carcinoid syndrome. Now, the serotonin is not the only hormone that neuroendocrine tumors can produce. So we talked about that in the last video, but depending on where these tumors start in your body can really affect the syndrome that you might experience, or your tumors might not produce much hormone at all and you might not get any syndrome symptoms. But people with pancreatic tumours can sometimes rarely get insulin-producing tumours, glucagon-producing tumours. People with pheochromocytomas can get adrenaline-producing tumours. So there's lots of different sort of subsets of, we call them functional tumours. Serotonin-producing tumours is just one of those, but that's the one that leads to carcinoid syndrome. So that's the focus of today. So we get these symptoms. We get the carcinoid syndrome symptoms. Sometimes, as I said, it occurs because you've had some food, and sometimes people do have trigger foods with carcinoid syndrome, but not everybody does. So the short story there is, if you don't have trigger foods, you don't need to worry about altering your diet especially. But if you do have trigger foods, it's really worthwhile figuring out what they are. There'll be a resource in the notes for helping you to do that, so you can help manage your intake of those foods, and be prepared for, if you choose to have some of those foods, what might happen. So sometimes it occurs because you've had something to eat or you've had a stimulus. Like sometimes it's actually anxiety and stress that can actually cause that outflow of hormones, and you can end up getting, the bright red flushing. I have seen a lot of flushing in doctors' waiting rooms as people, hang out and wait for scan results and things. Yeah, I don't think I'm getting any comments in the feed, so that's interesting today. I'll just keep talking. The other thing that can happen over a longer period of time with carcinoid syndrome is that we know that the serotonin actually has a negative impact on our connective tissue, and there's another video especially on that. But essentially, if you're a person who gets carcinoid syndrome, you need to be having regular echocardiograms to check out the valves and the connective tissue in your heart. Sometimes it can also lead to connective tissues in the small intestine, so in the mesentery, which is the part of the intestine that keeps everything laid out very nicely in the nice sort of loose, loopy folds of the gut. And so some people with carcinoid syndrome, that can get really wonky and pulled in and scarred. So as I said, there's a video on that. I'll link to it in the notes. The other thing that does happen for a lot of people, actually probably more than 50% of the people who get carcinoid syndrome, the body, in order to produce the level of serotonin that you need to produce carcinoid syndrome, it uses up the body's stores of vitamin B3. And there is another video about this. I've got quite a library going now. But if you are a person with carcinoid syndrome, read the thing that I'm going to link to in the notes, but you really should be on a vitamin B3 supplement. Obviously, talk with your doctor about anything that you're putting into your mouth that's a medicine or a complementary thing, like what we would consider vitamins and minerals. But vitamin B3 is a really common deficiency for people with carcinoid syndrome, so that's important to keep in mind. So what do we do about carcinoid syndrome? And this is really important because there's things that we can do medically, but there's also some things that we can do in other ways as well. So certainly the mainstay and the first line of treatment for people with carcinoid syndrome is somatostatin analogues. Now, I've talked about this in a few things, but I'm going to go into it now. So on the surface of all of our healthy neuroendocrine cells are these little receptors. We call them receptors. They're a bit like a messenger porthole system, or, some people talk about them being a bit like a phone. They're a way of the cells getting the data from the body that they need to be able to do their job. So it's a messenger system. What happens with somatostatins is that, so they're somatostatin receptors, but what happens with these monthly injections of somatostatin analogues is that they are a bit like a child-safe cover for those receptors. So they stop the tumours from being able to misinterpret the signals from the body and produce too much hormone. And actually those childproof covers, they're really clever. The somatostatin analogues are really clever in that they tend to turn tumours to sleep. So it's not even that they are, it's not only that they are reducing the tumour's response to the signals from the body when you eat, but actually they just reduce the tumour's activity in its entirety, both in terms of the production of too much hormone, but also in terms of their growth. So they're pretty clever drugs. People don't like them because they are a monthly butt injection. There's a video on that. But they do a really good job at curbing the production of hormone and also curbing the growth of tumours. And actually people can have tumour shrinkage as a result of somatostatin analogue injections. So they're really very much a mainstay. So there's two on the market in Australia. There's lanreotide and there's sandostatin LAR. Very quickly, both of them have home injection support services. They change those home injection support services a little bit more frequently, less frequently than I change my sheets, but seemingly quite frequently. So there's actually been an update in the provider for the program that supports the home injection of lanreotide. They've changed their name essentially and the company who's providing that. So just if you're on that injection and you're in a home injection support program, you'll probably have noticed some changes there. So now there is another drug that is that targets the production of serotonin, and it works in a really different way. So it's not a somatostatin analogue. It actually works to reduce the body's ability to sort of it reduces the building blocks essentially of the serotonin, so the body can't produce as much. It doesn't have as much raw material available. So that drug is called telotrestat, and it's specifically for people on monthly injections who are still getting breakthrough and especially diarrhea. So it's an oral medication. It's not available on the PBS, but there is a compassionate access scheme. So if you're getting diarrhea despite being on the monthly somatostatin analogue injections, it's worthwhile. My neighbour's just decided to chop down a tree, so little background humming there. My apologies. So what was I talking about? Telotrestat. So if you are getting breakthrough diarrhea that we feel it, or that your doctor feels is carcinoid syndrome related, so not as a side effect of the injections, but actually because of carcinoid syndrome, it's worthwhile asking them about, whether it could be considered as part of your overall treatment plan. So I'll let you talk with your doctor about that. The other treatment that specifically can reduce carcinoid syndrome, of course, is PRRT. So that's peptide receptor radionuclide therapy. Often it's called lutate therapy, and we call it PRRT for short. The other term that is often used is theranostics. And what that does is actually targets the same receptors, so those somatostatin receptors, but it targets them with a radioactive isotope, which is taken up into tumour cells and kills tumour cells. So with every drug and every intervention we go down the list, they do have more potential for side effects. So somatostatin analogues, they're a monthly injection into your butt, or if you're self-injecting lanreotide, then it can be injected into the thigh. There are some significant side effects with those injections. There's no two ways about it, and it's really important to talk with your doctor about the risks and the benefits of any of these medicines. PRRT has a different and more extensive list of side effects. Look, a lot of people ask why it's not given as first-line treatment to every person, and the reason is that it's essentially a bigger hammer to try and do the job, and if they can do the job with a smaller hammer and create less harm, that's a better option. And a lot of people are very stable on just the injections for years. So there's no point in bringing in the big tools if we can do the job with a less toxic treatment. But PRRT is also given, and it's very effective, both for reducing symptoms of neuroendocrine tumors, including carcinoid syndrome, and but also tumor growth. And once more, we see people who can be stable for many years following that treatment. So that's a really awesome thing to know about. And if you're on the monthly injections, you're getting a lot of carcinoid syndrome, you're seeing an oncologist, and you've been on that treatment for a while, then look. One of the things about neuroendocrine tumours is that we, as health consumers, as patients, we need to get comfortable with asking tricky questions. Sometimes it can be really awkward to try and ask your doctor, do you think there's anything else we need to do? are there any other treatments that could be on the table here? Is it worthwhile me talking to a different doctor, getting a second opinion just to confirm that we're all on the right track? I can't pretend that these are not awkward questions to be asking, but they're really important because neuroendocrine tumours are uncommon. No one knows everything about them, and so sometimes we do need to call in the expertise of a multidisciplinary team or another senior oncologist or a nuclear medicine physician or an endocrinologist in on the picture so we can kind of get a bit more control over your disease and your symptoms. So we've talked about somatostatin analogues, we've talked about telotrestat, we've talked about Prrt. The other things I just did want to mention in the management of carcinoid syndrome is once again going back to the heart issues and the issues of vitamin B3. So with the heart, if you're experiencing, especially if you're experiencing carcinoid syndrome and have been for some time, super important to keep on top of those echocardiograms. Often they are normal, usually they are normal, and sometimes because people can have so many normal echocardiograms in a row, it can just sort of slip people's minds. But it really needs to be done at least every year, that echocardiogram. They need to be looking at the right-hand side of the heart. So if it's been more than a year and you haven't had an echocardiogram, talk to your doctor about it. You can actually talk to your GP about it in between oncology appointments just to get that checked. Because sometimes that valve damage can kind of sneak up on you and then cause quite significant symptoms. And, the last thing we want to do is control the tumour, but have you really badly affected by a heart valve problem? So we want to keep an eye on that. Now the other issue, as I said to you before, is vitamin B3, and this is something that's newer. Not every doctor knows about this issue of vitamin B3 deficiency with carcinoid syndrome, so you might not hear this from your healthcare team. Make sure you read the information that I'll post the link in the notes about vitamins and minerals and nets, because once again we could manage your tumours quite successfully, but you can get very, very, very sick with a vitamin B3 deficiency. A vitamin B3 supplement. So the fact sheet has got all of the information about the dosage and the indications and all of, as well as lots of other vitamins and minerals that can be a problem in NETs. So make sure you have a read of that. So I've just realised that having not been able to see the comments, it's a lot quicker to do these videos, and it's maybe I'm getting more concise. I'm not sure. I am actually just going to attempt to have a look and see if I can see the comments on another screen, so on another window. So just bear with me for a second, because I just want to make sure that I haven't missed any burning questions that I really should have asked. Yeah, nothing wants to play with me today. It's really sluggish. So look, I'm going to probably leave it there, and you get a concise, or a slightly more concise, I wouldn't say concise, but maybe slightly less waffly version of a back to basics video than you might normally get. So thanks everyone for tuning in, and look, leave your questions in the notes. I think it might be even more important today because I haven't been able to see the questions and answer them as we've gone along. But yeah, leave your questions in the notes, and I'll attempt to either address them, with the comments section, or if it warrants an addendum to another video, then I'll make sure I address that next week. So before we finish, and look, if you're watching via YouTube or anything, or if you're not part of our Facebook private discussion group, you're welcome to turn the video off at this point, but just I usually do a few little plugs and a few little bits of housekeeping at the end. So the first thing I wanted to let you know is that next week we've got our regular national Zoom group catch-up. It's on Tuesday afternoon, and if you're in Victoria or New South Wales or now Queensland time, it's between 6:30 and 8 p.m. on Tuesday. So that's our evening version of that group. We run monthly. We alternate between a Tuesday evening and a Friday afternoon. So That's available via the Facebook private discussion group. If you're watching this via YouTube and you want to know more, you can contact me via the contact details in the notes. The other thing I wanted to let you know, and this is really very much related to Zoom and using Zoom for groups. So actually that monthly group has been really quite popular. We've had, most months we've had quite a good number of people who've come in and had a really fabulous discussion, I think. And, I've learned a lot from talking to people about their experiences, and I know people really appreciate hearing from each other and having a chance to really share your story. Our face-to-face support groups during COVID, you'd have to be under a rock if you didn't realise they all had to transfer to Zoom meetings. And that's been probably a little bit more tough for the groups that would normally meet face-to-face. And a lot of those groups have got really very tiny, which is we understand, like, who is not zoomed out after 2020. But we're really excited with the... and it's a work in progress, and it's something that we're monitoring carefully, but we are planning for the return of face-to-face support groups as of our June round of meetings. We've had a pilot meeting co-branded with. We've had a chance to road test our COVID safe plan with that group, and we're getting closer to getting that right, or to feeling like we all know what we're talking about. I'm talking a lot with our support group facilitators about how to do that safely in their local groups. But what we're very keen to get from everybody is some feedback about how you feel about returning to face-to-face support groups. We will, and probably it's really important to say up front, is that we will be encouraging everyone who's attending those groups to do so once they've had a vaccine. So we're wanting to minimise the amount of risk of contracting COVID from our support groups as absolutely possible. But knowing that the vaccines are becoming much more available now, we're hoping that by those June meetings, most people with NETs, if they want to go ahead and have a vaccine and they've been advised it's safe to do so, that will be well and truly in progress. So yeah, face-to-face support groups, we're really hoping for that to happen. Feel like, is that something that you would feel confident to do? We also have had some people suggest that, well, maybe we can run hybrid meetings with the face to those who are feeling good about coming to a face-to-face meeting, coming in person, but also maybe setting up a computer at the same time and trying to have people zoom into those face-to-face meetings via their computer at home or via their mobile device at home. It's a bit complicated. There's a bit of tech stuff. There's a bit of equipment to think about. We've got to try and work out how we make a webcam work with physical distancing of 1.5 metres between everybody. So we've got a bit of sort of sussing out to do to make that work for everybody. And what we're really trying to get a sense of is, how many people are there who really want to do a sense of what the issues are, so that we can really get our planning skates on and make that happen as best we can for everybody out there in unicorn land. So I have put a survey up in the Facebook private discussion group today, with my most humble apologies, because I know we are all surveyed out. I have been surveyed about every aspect of COVID, to the health of my toenails, to my eyes and my lungs and everything else. I'm a bit over surveys, and a bit of the same way I'm over Zoom. I know that you will be the same. We've talked with people a lot about their experience of COVID. So we tried to be really judicious with the questions. We tried to not pepper you with too many questions. All of the questions are optional. So if you look at a question and you think doesn't apply to me, just skip through it. But we're really, really super keen to get that feedback so that we can do this in the best way possible, so we can meet your needs in the best way we can. So please have a look for that survey link in the Facebook private discussion group. I'm also going to be pestering everybody on our database list who is currently part of a face-to-face support group with an email with the link in that. So if you get an email, please do fill in the survey. It's going to be, this information is going to be really vital for us in making our plans for this return of support groups. So I'm just looking at my list, and I think I'm pretty much at the end of my list. And having not been able to see the comments, I don't know what's on your list, but I'm sure I'll find out when I finish the video. Look, it's fantastic to have been able to join with you today. Thank you for your patience. I know we had a different speaker planned for today. I'm excited because Professor Jazz Samra will be about upper gastrointestinal pancreatic surgery, liver surgery, all of those things. But the exciting news is that on Friday week, so a fortnight from today, we've got Dr. John Layden. Now, Dr. John Layden is an anaesthetist, but he's also the co-founder of formerly the Unicorn Foundation and now Neuroendocrine Cancer Australia. There's not much about carcinoid crisis that John doesn't know, and I think that's going to be a really fantastic kind of follow-up to today's session where we've talked about carcinoid syndrome. I purposefully stayed right away from carcinoid crisis because I know we're going to be talking about that in depth in a couple of weeks. Now, it's been as the subject of quite a bit of interest because people have been thinking about, well, what happens if I have an allergy to a vaccine and they need to use an adrenaline injection, but it does come up frequently in relation to things like dental work, surgery. So we're going to take a really good deep dive into that in a couple of weeks, and I'm excited that John will be joining us for that. He's promised to not do it from theatre. Sometimes he rings me from the operating theatre and I get the beeping of the person's machines in the background, which makes me rather nervous, but he's not going to be doing it from the theatre. He'll be actually able to just, be able to focus and help answer our questions about carcinoid crisis. So that leaves us with a Facebook Friday next Friday where I have, I've got a list of things I could talk about. Some of the things, I'll tell you some of the things that I've been thinking about talking about or that I have on my list to look at in the future. Peripheral neuropathy is one. I've got on my list to talk about other genetic syndromes like MEN1. So that's a complex one, but it's something that I'm aware that we haven't really taken a good look at. I'm also very aware that we've talked very little about pheochromocytomas and paragangliomas, which is such a tongue twister of a combination of words, but again, really keen to make sure we do something on that at some point. Hair and skin changes is another one that I've got on my list to talk about. What else have I got? I want to talk about immunotherapy. I want to talk about bowel blockages. I want to talk about oscopies, so gastroscopies and colonoscopies. Look, there is a huge list and it goes on. Nausea was another one. Advanced care planning is still on the list. What happens when you're asked to choose between treatments, gallbladders, there's lots. So maybe let's do a bit of a poll and see what you would like next week's Facebook Friday to focus on, and I will be really guided by your feedback. And if we get onto that early in the week, I've got a bit of time to do some homework too, so I can tell you some competent information. So look, thank you. I'm stopping. Having said that I was going to be concise, I've spent an extra 10 minutes blabbing on about housekeeping. So thank you for hanging in with me. It's lovely to see you today. I'm in the office this afternoon still, and then next week I'm in on Monday. I've got a training course on Wednesday, so I'll be out of the office Tuesday, Wednesday, and then back in the following Friday. So if you need to get in touch with me, all of the contact details will be in the notes. It's been lovely chatting with you today, and I hope you have a good weekend. I'll look forward to talking to you next week. Bye, everybody.